Hello, my dear students. Today, I'll be talking about DCR, that is dacrocystorhinostomy. So before starting my class, let me ask you a simple question. So you're stuck in heavy traffic. What would you do? I'm sure majority of you will resort to this, but what should you do? You should take the next alternative route available, right? So just remember this and walk with me as I take you through DCR. So now, after my class, you should be able to tell me what is DCR, what are the indications and contraindications, types, steps, and some basic complications of DCR, that's all. So, this is a 53-year-old male who came to me with complaints of recurrent episodes of swelling, epiphora, and discharge for the past 6 months. Any guesses into the diagnosis? Yes, correct, chronic dacrocystitis. So, this patient is an ideal candidate for DCR. Now, let me revise for you how normally tears flow in our eyes. They are produced by the lacrimal gland, flow through the conjunctiva, into your upper and lower canaliculi, through the nasolacrimal duct, eventually into the nose. So what happens when there is nasolacrimal duct blockage? There's heavy traffic for these tears to flow, right? So now you create an alternative route for them. Easy. So now, when do you do DCR? You will do it in nasolacrimal duct blockage. When can nasolacrimal duct blockage be there? It can be primary or secondary to some other causes like deviated nasal septum, or it can be persistent congenital. So it's equally important to understand when not to do DCR, when there is lacrimal sac malignancy or active infection. So now you know when to do DCR. So how will you suspect that the patient has a nasolacrimal duct blockage? Patient will present to you with recurrent watering and discharge, and because stagnation of tears is there, they will present with recurrent swelling, pain, and infection. So now you know the what and when. Now let us move into the how. So there are basically 3 approaches to DCR: external, endonasal, endocanalicular. Let us move into the surgical details now. First step of external DCR, make a skin incision around 10 to 12 mm in size. Pointed to remember, preserve the angular vein, it's here. Around 8 mm from the medial canthus, remember not to nick it. Next, you will reach the orbicularis oculi. You have to do a blunt dissection of the orbicularis oculi. Remember not to cut through the fibers. Next, you will come across the medial palpebral ligament. Just lift the anterior limb and reflect it laterally. What do you see? Lacrimal sac. Pointed to remember, do a subperiosteal dissection of the lacrimal sac and reflect it laterally. Now your area of interest is here, you come across the lacrimal fossa. Understanding the anatomy of lacrimal fossa is important. It is made up of 2 bones. Which ones? Maxillary, lacrimal bone. So now the hero of your surgery comes, the rongeur comes, you make an osteotomy, and the bone in the center is gone, right? So this leaves you with lacrimal sac on one side, nasal mucosa on the other side. Now what you have to do, you have to connect them. How do you do that? You create flaps on both the mucosas in the shape of an H. What does this leave you with? 4 flaps. 2 on the nasal mucosa, 2 on the lacrimal sac. You cut off the central 2 posterior flaps and you connect the anterior flaps together. Now your tube is connected, your tube is done, your surgery is done. You close the skin. So this is all about external DCR that I wanted to tell you. Now let us move into our second approach, which is endonasal DCR. So basic concept of DCR remains the same in this surgery. You have to connect the lacrimal sac with the nasal mucosa. You just go in through the nose with an endoscope. Benefit cosmetically superior because you're not giving any incision, but it needs a little more expertise. So this is a small video showing you how to do an endonasal DCR. First structure that you will encounter will be nasal mucosa, right? Now you reach your lacrimal fossa with a bone drill and a rongeur, cut, make an ostium. You reach the lacrimal sac here and you connect it to the nasal mucosa and your surgery is done, voila. Now, endocanalicular DCR, whoever gets back to me with this answer in the next class will get a chocolate. Let us move into some basic complications. They can be hemorrhage. They can be some syndrome. When you made your osteotomy, but it's a little superior, so it's not sufficient. Then failure reach stenosis like every surgery. Then orbital emphysema or a CSF leak. Now let me summarize the class for you. So basically what does DCR do? It creates an alternative route for the heavy traffic of tears. It is indicated in nasolacrimal duct blockage, contraindicated in active infection. Basically 3 types of DCR and most commonest complication being hemorrhage. Most important take home message, whenever you are stuck in traffic, road rage is not the answer. So in next class, we'll learn how to diagnose nasolacrimal duct obstruction. Thank you.
Why in an infection we can't do this DCR?
Very good question. So whenever there is infection, you should understand that you will never proceed with the surgery first, because this will increase the infection. It will have the risk of spreading of the infection. So whenever there is infection, whenever the patient has acute dacrocystitis, first give the patient a course of antibiotics, let the infection resolve, find out why that infection is happening. It's a local cause or an NLD obstruction. In case you find out that that active infection is because of nasolacrimal duct obstruction and the infection has subsided, then go ahead with surgery. So do not jump into a surgery first.
But in a dacrocystitis, can't we do an endonasal DCR then?
Active infection you shouldn't do.
Ma'am, I came across a child who came with watering, but then when I saw there were no puncta only, but the child had a chronic dacrocystitis. So what will I do in this case, ma'am?
There was the procedure called as a Jones procedure. With conjunctival dacrocystorhinostomy you can do together. So you can go for those procedures whenever. So basic concept you should understand about nasolacrimal duct blockage and DCR is the other structures of your lacrimal pump should be functional. So that is a very important thing to understand. Only nasolacrimal duct is blocked, but your puncti, your canaliculi and the lacrimal function as a whole should be functional for you to take up the patient for DCR. That is something that you should remember. Good point.
Thank you, ma'am.
Teacher, how should I decide that this patient should go for endonasal and this patient should go for an external?
Excellent question. You have applied, you have thought about it. Okay, so whenever you think that a patient has some systemic comorbs, for example, a patient is 80 years old, 90 years old, has many systemic comorbidities, so that patient we might have to take up under general anesthesia. So endonasal DCR usually are done under general anesthesia, but external DCR you can still take up under local anesthesia. So whenever there is any contraindication to general anesthesia, you might prefer an external DCR, but whenever general anesthesia is absolutely necessary, you will go for endonasal DCR. And whenever, another thing to remember, whenever your nasolacrimal duct blockage is happening because of an endonasal cause, like deviated nasal septum, or there is something endonasal, you can tackle it along with that dacrocystorhinostomy, right? So you will try to go endonasally and you can tackle both the things together. So even if you do the surgery, if the nasal pathology is not corrected, your surgery is of no use, right? So do a thorough evaluation, find out what is the cause of nasolacrimal duct obstruction, why you're doing the surgery, why it's imperative, do a systemic workup of the patient, find out if the patient can be taken up under GA, and only then take up the patient.
Thank you.